right. Looks like everybody got in from the waiting room okay. Hi, everybody. My name's DB Sanders, and Jim Schmiel and I are the co-chairs for the pediatric track for the Fellow Symposium at ATS, although we're not at ATS. But thanks to everybody who's logging in and joining, and anybody who's watching this later. This will be the first of several talks that we have coming up. Oops, let me see if I can advance my slide. So today's speaker is going to be Carolyn Kercsmar from Cincinnati Children's Hospital. She's the director of their asthma center there, and she's going to be talking on severe asthma. And these slides are going to be available later from the ATS website. We'll remind everybody to please include your evaluation of today's webinar. You can see on your screen the QR code that you can use to get to the evaluation webpage. There's also should be a link in the email that you receive. We definitely take this information in mind and have made changes to the program based on your feedback. So we really appreciate it. During the talk today, if you have a question, please enter it into the chat, and I will sort of moderate and try and get those questions to Carolyn either during breaks or at the end. If it seems like a question that's in there is hard to understand, or it's just easier to talk, you can also ask to be unmuted, or may unmute you to ask Carolyn directly. Hopefully most of you will be coming to the next webinar on Wednesday when Chris Orman from Children's Mercy will be talking about congenital abnormalities of the lower airways and lungs. And you can see there the registration link, which will be available to sign up for that ahead of time. And then one last slide just for your information, if you're interested, before we switch over to today's talk. There are these, the training forum for critical care. This is for non-critical care physicians thinking about the assessment and treatment of COVID-19 in case this is something that, that you may be required to do or may be just interested in doing. So I'm going to stop sharing the slides here and let Carolyn share hers. Thanks again for everybody who is joining today. Okay.
All right, as soon as I can find my screen again here, here we go.
That looks good.
All right. And unfortunately, they've just started vacuuming outside my office, so hopefully the noise won't carry in and it'll only be temporary. So thanks to everybody for being here, even though I can't see anybody's smiling face just yet. I appreciate everyone being here today. I don't have any disclosures. And what we're going to talk about today is a little bit about the definition of severe asthma. It's a little more complicated than at first glance. A little bit about the pathogenesis and the pathobiology of severe asthma. Very briefly touch on the differential diagnosis, and then spend most of the talk on treatment of severe asthma. So a very wise pediatric pulmonologist once told me it's always a good idea to start out with a case. So here's a case of a young man that is representative of many of the patients that frequent our asthma clinics in pulmonology. So this is Daryl. He's 9. He's had asthma for some time. He had his first hospital admission when he was about 7 years old. And he now has about 1 hospital admission a year, about 4 emergency room visits. He takes 4 different asthma medicines. He says multiple things will bother his asthma. And when we measure his lung function, it seems to be persistently low. A few other things to know about Daryl is he lives in inner city Cincinnati. He usually lives with his mom, but he spends a lot of weekends with his dad and also with his aunt and his grandmother. So he has a lot of different caregivers. He sometimes has trouble getting his medicines due to changes in his insurance. And he admits that sometimes he forgets to take all those medicines on some days. In addition, their apartment is pretty old, pretty dusty, pretty moldy, so he has lots of exposures there. So does Daryl have severe asthma? Well, let's talk a little bit about what's in the definition of severe asthma. And there are a number of them that have been published. The one that often gets quoted is in a combined statement by the American Thoracic Society and the European Respiratory Society on what constitutes severe asthma. And generally requires that a patient has treatment with high-dose inhaled corticosteroids and a second controller medicine, or requires systemic corticosteroids for at least 50% of the previous year. On this treatment regimen, patients may or may not maintain asthma control. So you can be well controlled or not well controlled, but you have to have that level of treatment. It's currently estimated that maybe about 5, maybe a little bit higher percent of all asthmatics are severe, so it's not a lot of patients, but they consume a lot of resources and have a lot of morbidity. And the other thing that I hope we can impress upon you today is that even when we say severe asthma, we're really talking about a heterogeneous disorder within the context of asthma as it relates to a number of phenotypes and endotypes. So this is a nice little diagram that the WHO put out to talk about or to help define or get you to think about severe asthma. So the two paradigms here is that you can have someone who has well-controlled asthma with maximal therapy, as we said in the previous definition, or poorly controlled asthma with maximal therapy. So within the patients who are well controlled, those patients might be called severe therapy responsive asthma. And then in the group of patients who are on maximal therapy but still aren't well controlled, they have therapy resistant asthma. But then you notice this other big group of patients here called difficult to treat asthma. We're going to talk a little bit more about that in a minute. And that they often get confused with having severe asthma, but really might not. And since this is a WHO definition that really encompasses a global view of asthma, there might be some patients who have untreated asthma because they are severe asthma because they're totally untreated due to lack of available resources. So what do we mean when we say uncontrolled asthma? That definition can be pretty broad and generally refers to patients that have poor symptom control. And you can measure poor symptom control by using some standard tool to do that, an asthma control questionnaire that has a score that's consistently above 1.5, or probably what's more commonly used in children is an asthma control test score that's less than 20. So that measures largely symptoms, but some patients might not have a lot of symptoms, but have a lot of severe exacerbations. And by that we mean 2 or more bursts of systemic corticosteroids in the previous year. In addition, it can mean at least 1 hospitalization, an intensive care unit stay, or the requirement for mechanical ventilation in the previous year. Another component of the definition is the patients who have airflow limitation, usually measured by an FEV1, or particularly in pediatric patients, an FEV1 to FVC ratio that's reduced. Another thing that can help you define poorly controlled asthma, or is sometimes included in the definition of severe asthma, is that patients that are on that maximal medical management, but as soon as you try to taper it, they lose control of their asthma. So if we look a little bit more closely at some of this terminology, because I think it does get confusing, uncontrolled asthma, again, it refers to a patient who has either frequent symptoms and or frequent exacerbations. Patients with uncontrolled asthma that might mimic severe asthma are those patients that really might have milder disease so that their asthma could be controlled with lower doses of medications, not that maximal dosing that's required for the definition of severe asthma, if they would take it and if they would be prescribed the correct medication. Patients with difficult to treat asthma, again, often get called severe, but they have uncontrolled asthma often on high doses of medicine, but again, they may have a number of other factors that lead to that poor control, such as they don't really have asthma. Their inhaler technique is terrible. Their adherence is inadequate. They have comorbidities that make the asthma difficult to control. But if all those things were addressed, the asthma would really be easier to manage and really not inherently severe. And then last is the definition of severe asthma, which really comes about, or gets called in the GINA guidelines, as a retrospective definition, because you really have to address the other two steps that are above it about what does it take to control someone's asthma, and if you address the difficult to treat asthma, and that this is asthma that's still uncontrolled despite maximal optimized therapy and treatment of contributory factors, comorbidities, poor treatment adherence, et cetera, and that this asthma then will worsen when you try to decrease treatment. So it's very important, one take-home message is to be able to decide who has uncontrolled asthma, who has difficult to treat asthma, and who truly has severe asthma. So how does somebody get there? What does severe asthma look like? And in general, almost all patients that have severe asthma will have some sort of structural abnormality or alteration in their airways. They almost all have an increased smooth muscle mass in the airways. They'll almost all have increased basement membrane, so there'll be basement membrane thickening, and there'll be either epithelial damage, or maybe it's just dysfunctional or dysregulated airway epithelium that is, again, intrinsic or inherent to patients with asthma. They may also have some vascular abnormalities, so increased vascularity in the airway, which makes them more subject to edema formation that leads to the airway narrowing. Eosinophilia. Eosinophils have been viewed as the villain in all kinds of asthma, and particularly in severe asthma for decades. They kind of go in and out of favor as the bad player. And I think that's still true today, that we don't completely understand the role of the eosinophil in the airway, because severe asthma can occur in the presence of lots of eosinophils or with very few eosinophils in the airway. And severe asthma is sometimes thought as something that develops over time. And so patients who have had their asthma for a longer period of time, that started earlier in childhood, might be at risk of developing more severe asthma. So this is a great diagram that was published in a nice review article in the Lancet a couple of years ago that really kind of helps you think about this sort of heterogeneity of severe asthma. So if the normal airway is here, that these other sectors represent the airway pathobiology that can go on as a result of a number of mechanisms. So while the vast majority of asthma in children, whether it's mild or severe, is really thought to be allergic and eosinophilic in nature. So we think that these are patients that become sensitized to largely aeroallergens that interact with and or damage this already dysregulated airway epithelium. Those allergens get presented by dendritic cells to innate lymphocyte, type 2 lymphocytes, which then can result in the production of largely IL-4, IL-3, some IL-5, and those mediators are very important in either the isotype switch of B cells to produce IgE or to promote the survival and activation of the eosinophils, all largely driven by allergen sensitization. However, there is another phenotype of asthma that is eosinophilic but non-allergic. So very similar mechanisms, except the drivers really might not be allergens, maybe pollutants, maybe microbes that likewise injure the epithelium, that these are different pathways with thymic-stromal lymphoprotein and IL-33 interacting again with those type 2 lymphocytes. Now this is largely an IL-5 or a PGD2 driven process that again causes the mechanisms of the injury to the airway. Then there's another, the non-eosinophilic, non-allergic forms of asthma that are probably maybe 10 or 15% of pediatric asthma. So these are non-eosinophilic, and they can either be paucigranulocytic, so they're not really a lot of eosinophils, not really a lot of neutrophils, but nevertheless, this impaired epithelium, this may be due to exposure to pollutants or stress that then goes on to cause airway reactivity. Or there's neutrophilic asthma. This is maybe, again, driven by IL-17 and IL-3, lots of neutrophils in the airway, again, as a result of exposure of pollutants and oxidative stress that drives this airway injury. So eosinophilic asthma, non-eosinophilic asthma, all of these phenotypes and endotypes can be severe. Just a quick little look at what the airways look like. This is from an old study, but these are a group of patients that had normal, these are airway biopsies from patients that had normal lung function or chronic obstructed lung function, just to show the difference in the airway smooth muscle mass in those that have normal lung function but severe asthma versus those that have persistent airway obstruction. So again, pointing out this heterogeneity. And this is just a slide comparing a normal airway, non-asthmatic airway with an asthmatic airway, and all these arrows are eosinophils in the submucosa. The interesting thing in this study, though, is the number of eosinophils in the submucosa in mild, moderate, and severe asthmatics did not differ. So again, getting back to what are those eosinophils doing there? What's the mechanism of them causing disease? Just a little bit more, we touched on some of these pathways, just try to review it for you quickly here, that because this is going to play into how we might treat this. So again, probably 85% of asthmatics, at least pediatric asthmatics, are thought to be allergic, have this T2 high inflammation. So these are IL-4, IL-13 pathways, largely associated with allergens, recruitment of eosinophils in the airway, and a high IgE, again, due to that allergic sensitization. There's some other markers, periostin and metalloproteinases, that are increased in patients with this phenotype. This isn't a terrific marker, periostin, in kids because it can be elevated in kids who are growing, so it's a better marker in adults. If you have non-allergic but eosinophilic asthma, we think that IL-5 and IL-33 are the other mediators that drive this, again, through their actions with the type 2 lymphocytes. So these are patients that are non-allergic, but they've got a lot of eosinophils in their airways. They tend to sometimes be patients who have their asthma occur a little bit later in life. They tend to have a lot of exacerbations. And interestingly, they tend to be moderately resistant to inhaled corticosteroids. They need very high doses, but they'll respond to systemic corticosteroids and anti-IL-5, and we'll talk a little bit about that, more about that in a minute. Patients that have T2 low asthma are patients that, again, are non-allergic and largely have airway neutrophilia. They can have a lot of variable airflow obstruction, a prominent bronchodilator response that never seems to go away. And these patients tend to be highly resistant to corticosteroids. We'll talk again a little bit more about them, but because this is driven by neutrophilia, that perhaps an anti-neutrophilic treatment would be helpful for these patients. There's not a lot of that currently available, except for something like macrolide antibiotics. So these patients, again, tend to be relatively steroid resistant. So all those kids you see in your clinics that swear they're taking their medicines but really aren't getting better, very well may have these pathways as being prominent. That steroid resistance, again, can come about by a number of mechanisms, including patients who have a lot of ongoing allergen exposure, high IL-2 or IL-4 levels in their airways, and a shift to glucocorticoid receptor beta, which are not very active. There are other mechanisms involved that we saw in that cartoon a little bit earlier, that predominance of PGD2, thymic stromal lymphoprotein, IL-18, interferon gamma pathways that are upregulated in these patients that are non-eosinophilic may also contribute to the underlying pathophysiology in their airways. So how do you know somebody with severe asthma when you see them? Well, it's not terribly easy sometimes because it is heterogeneous. But by and large, these are the characteristics of individuals that will have severe asthma. They tend to have a high degree of atopy. So they're generally sensitized to multiple aero allergens, and that's usually defined as 3 or more allergic sensitization. They tend to have high IgE, so they'll be outside the normal range. They have peripheral eosinophilia, and that's in their peripheral blood. If it's a patient who's old enough to produce an induced sputum, That sputum will often have an elevated eosinophil count as well. It's generally greater than 3% of the cells will be eosinophil, or the eosinophil will be greater than 3%. They tend to have higher exhaled nitric oxide as well. In addition, at least a subset of them will have lower lung function. So that persistently low lung function, it's that proportion of kids you see in clinic, and every time you see them, their lung function is low, and they have a persistent bronchodilator response. Once upon a time in my career, I was convinced that every patient I saw who had a persistent bronchodilator response was just not taking their medicine. While some of those, that is still true, we now know that there is a phenotype that has a persistent bronchodilator response that's extremely difficult to eradicate, and that's a marker of severe asthma, particularly those that are likely to exacerbate. And again, while it's incompletely understood, we know that ethnicity and race can contribute. Children who are African American tend to have more severe, or more likely to have severe asthma, as are Puerto Rican Hispanics. The problem is, even within those groups, and just show you a little bit of data here to put this point home, is that even if you use those definitions to define severe asthma, even within that group, the patients will differ a little bit. So this is from a study that Ann Fitzpatrick group published a couple of years ago from the START group, and they looked, the severe asthma research project group, and they looked at patients who had severe asthma. They did some cluster analyses and found that there were two different clusters. They numbered them clusters 3 and 4 that contained kids with severe asthma. And even within that group, they found that one group seemed to have a lot of comorbidities and seemed difficult to treat. The other cluster had very refractory asthma, persistent low lung function. They started to have their asthma at different ages. Both groups were highly sensitized. One of them, the cluster 3, had reversible airflow obstruction, but that it was less so in cluster 4. They both required high doses of medications and oral corticosteroid bursts. But the group cluster 3 tended to have more comorbidities and tend to have obesity, and less frequently so in this cluster. So these groups of patients all meet the definition of severe asthma, but they behave somewhat differently. This is from that same study, just to again show you that you try to use it. You'd love to have a biomarker to predict who's going to do what, but that unfortunately is not so clear-cut either. So on the y-axis here, the percentage of blood eosinophils. This is the exhaled nitric oxide level. And so even amongst these patients who have low blood eosinophils and low exhaled nitric oxide, there's a fair proportion here, but there's also a fair proportion of kids that are up here with high eosinophils and high exhaled nitric oxide. So all these patients have severe asthma, but they don't all have clear-cut biomarkers to help you with that identification. This is another study that we did as part of the Intercity Asthma Consortium to identify patients that had easy to treat versus difficult to treat asthma. So this is about 300 kids from 10 sites across the country. And what we did here is follow these kids over a year on standard but adjusted therapy over that year. Did a bunch of biomarkers on these patients, and this is again just to demonstrate the heterogeneity of these groups. So we had 5 clusters of patients here. This is asthma severity on the y-axis and the degree of atopy from low to high on the x-axis. And you can see that there's a group of patients here who had pretty severe asthma, but very little allergy. And over here are the patients that we think of as typical of severe asthma, with a very severe asthma and a very high degree of atopy, and then this gradient in between. So these are just to really highlight that there are a number of different pathways that can get you to severe asthma. They vary amongst groups, and it makes, therefore, identifying these patients a little bit of a challenge. and the bigger challenge is identifying what is their phenotype, and then what is the underlying mechanisms that's driving that severe asthma. Be remiss if we didn't also talk a little bit about is it really asthma? And again, you'll remember that that's in the definition, or what might be causing you to call somebody difficult to treat or severe asthma is it's not really asthma. So here are some fairly common conditions. Vocal cord dysfunction is a big one. Patients may have airway malacia. They may have profound complications or comorbidities like reflux and aspiration. Foreign body in younger kids. Primary ciliary dyskinesia we know is probably more common than we think, and that has a broader phenotype now as well. Habit cough often gets called asthma. It's not, and can be very difficult to treat. And then these are some on the other side of the slide are some more less common conditions that can be confused with severe asthma, although most of those will have other manifestations that will help direct you away from asthma as the condition. But always important to ask, is this really asthma you're dealing with? What are those comorbidities you have to look out for? Certainly gastroesophageal reflux and or aspiration. If a patient has the symptoms for it, it's worth testing. Rhinosinusitis, which can be either infectious or part of allergy. If you believe in the one airway paradigm, it certainly indicates that if you can't control the upper airway inflammation, you're going to have trouble controlling the lower airway inflammation. Poor adherence is a big one. We'll talk about that a little bit more in a second. Ongoing allergen or irritant exposure. Many families don't recognize that they have a lot of exposures in the household. Obesity is still incompletely understood, but it's clear that patients who have obesity also have systemic inflammation that's increased and require more medication than their lean counterparts. And then there's clearly a bidirectional interaction between obstructive sleep apnea, and probably can throw obesity in there as well, and difficult to treat or severe asthma that's, again, incompletely understood, but clearly influences the management of asthma. A number of other comorbidities, again, that are much less common and usually fairly easy to recognize. So we'll talk about, just for a second, just to hit home, the important comorbidity that, back up there a little bit, and that's adherence. We all want to believe our patients, but we'll just throw this question in there about adherence. So the proportion of patients who are non-adherent to prescribed doses of daily controller medications for asthma is approximately what? I'm not going to ask you to respond to this, but think about it. Is it 10%, 20%, 50%, or 80% of patients? And it's about 50%, and you can look at almost any adherence study, and that number between 50 and 60% will usually come up. I'll just show you one example. This is a study I was involved with a number of years ago. Patients were in a very aggressive adherence intervention with lots of home visits, electronic monitoring of their adherence, and they were followed for about a year and a half. Very personalized asthma care. You can see this is fluticasone use. They were all prescribed 2 puffs to take twice a day. This is time here. You can see they all start out great, and then over time we have people down to about 50% adherence. Very, very typical. So patients often have very great amount of difficulty adhering to what we want them to take. So important to do that. More and more adherence monitoring devices are on the market. There's smart inhalers on the market now. It's going to be hopefully easier to determine really how much adherence a patient has. So if we move on to managing severe asthma, what should you do if you think that's what a patient has? As I mentioned, again, confirm the diagnosis. Is it asthma or not? Does the patient have comorbidities? We've talked about what those might be. Are they taking the medicine, and are they taking it properly? Improper inhaler use is still a big problem. There's a lot of different devices on the market now, meter dose inhalers, dry powder inhalers, breath actuated inhalers. They all have different techniques. Some patients have multiple kinds of inhalers and get confused on the proper techniques. So that's often a huge issue. We know that many patients have ongoing and unrecognized allergen or irritant exposures in the home from pets, from dust, mold, cigarette smoke, nitrous oxide in the home from cooking stoves are all big problems. Again, it gets to adherence, but behavioral issues both in the child and the parent, impaired parental mental health can contribute to the severity of child asthma or impaired adherence. And then shared decision making, we often don't take that into consideration. Parents will often smile and nod in the office and say, oh yeah, I'll be happy to do that, walk out and say, I'm not doing that. So it's very important to include parents in any treatment plan. So what are your options for treating severe asthma? Assuming that you've answered, you've been through that, all the things that were mentioned on the previous slide, and you think your patient really has severe asthma. So the options really are to go to pretty standard therapy. So inhaled corticosteroids plus the addition of a long-acting beta agonist and or the addition of a leukotriene receptor antagonist. However, I think you're probably all aware that at least montelukast now has a black box warning added to it because of concerns over potential significant behavioral abnormalities, and so it's a little bit less likely, or maybe a lot less likely, to be used as an add-on drug. The addition of a long-acting muscarinic antagonist like tiotropium, should you put your patient on chronic daily or every other day oral corticosteroids. And then the ever-growing area of biologic treatment for asthma and severe asthma. We'll talk a little bit about that. And then some other things that are a little less well studied but are all possibilities as well. So should you treat your patient with high-dose corticosteroids? The answer is if they have an eosinophilic or an allergic eosinophilic phenotype, by all means. However, even within those groups, a fair number of patients have at least a relative corticosteroid resistance or insensitivity. So in one study, the study at the bottom that was published again by Ann Fitzpatrick's group, they gave all a cohort of patients who had severe asthma injected triamcinolone and found that about 43% of those patients improved and became controlled after that steroid dose. In the study that was published in the European Respiratory Journal, they used a very stringent definition of what it meant to get control of your asthma if you had severe asthma following 2 weeks of systemic corticosteroids. That you had to have improvement in symptoms, improvement in lung function, a decrease in your exhaled nitric oxide, and an improvement in your bronchodilator response. And out of about 100 children, only 11% improved all of those measures. And in another study of adults, as many as 30% of patients with severe asthma needed both oral corticosteroids as well as high-dose inhaled corticosteroids for control. So relative steroid resistance is pretty rampant amongst the severe asthma population. Again, it's more likely if the patient is obese. There's some evidence to suggest that if they have low vitamin D levels, they'll have some steroid resistance. If they're smokers, if they have ongoing allergen exposure, and if you've misphenotyped them so that they really are a low T2 phenotype, not high, they will be relatively resistant to corticosteroids. This is just some data from the Fitzpatrick study I talked about a minute ago, and that you can see here. These are the proportion of patients, or the asthma control score in patients who before and after they got the triamcinolone injection, and you can see that patients who are a little more symptomatic to start are a little more likely to improve, but that's not true for all the patients. The patients who have a high symptom burden before and after triamcinolone also vary, and there's not a lot of improvement in lung function pre and post triamcinolone. So a lot of variability in response. What's the mechanism for that? Still unclear. But these are the patients who achieved control after the triamcinolone injection. These are the patients that did not. This is the gene expression in peripheral blood in these patients, and you can see there's a clear pattern of difference here. These were some changes in or decreases in gene expression in a few genes related to IL-2 and IL-10. So again, probably relates to who's going to respond. Really depends on what their corticosteroid response elements are. Tiotropium, what will that do for you? So this is an antimuscarinic agent that largely helps with bronchodilation, predominantly in the large central airways. It's now approved for kids as young as 6 years of age. There are several studies that are out there. This is a nice large study that was published a couple of years ago, showing again that the primary effect is on improving FEV1, either the absolute FEV1 improving with 5 or 2.5 milligram dose versus placebo. This is the percentage improvement here. So it's a nice drug to help improve or gain you some improvement in pulmonary function, but it really didn't improve, change the symptom improvement in these patients a great deal. Generally well tolerated. It's a once a day drug. A lot of patients like to take it. The device is pretty slick in the rest of that. So it is a reasonable, well tolerated, fairly safe addition. But we said that there are a lot of pathways for causing that inflammation in patients with asthma. So can we target some of those pathways a little bit more directly rather than just sort of a global anti-inflammatory, global bronchodilators for asthma? So again, this is a nice diagram that shows a number of the target pathways. So you could target something like the IL-4, IL-13 pathway. IL-4 and IL-13 share a receptor. We said that these will cause isotype switch in T cells to B cells and start generating IgE. So if we could block this pathway, we should get some improvement in asthma management. If you don't do that, then maybe we could just target that IgE. So if patients have a lot of IgE because of marked allergic sensitization, we could block the IgE. We could go down the other pathway to get the non-allergic but eosinophilic patients by blocking IL-5, which is the primary promoter of eosinophil migration and activation. Another thing that would be maybe even better and a little bit more of a master switch is if we go more proximal in the pathway, try to block the TSLP early on so that we prevent the activation of dendritic cells launching either one of these pathways. We could go after PGD2 for those that have Th2 or low inflammation, or when all else fails, we could certainly try something like decreasing that smooth muscle mass by the technique of the highly invasive technique of bronchial thermoplasty. So, okay, those are lots of targets. How do we decide what to choose? So here's another clinical scenario, a little bit of a question. Again, a typical patient we might see in our difficult to treat asthma clinic is a 12-year-old boy who has severe asthma being considered for biologic therapy. He's got a normal FEV1. He's a bit overweight. He has an elevated peripheral blood eosinophil count. He has a very high IgE, and his only allergy is to eggs. So what would be the best biologic for this patient? Omalizumab, breslizumab, benralizumab, or tralokinumab? The correct answer here is benralizumab, and we'll try to go through why did we pick that one. So the current biologics that are available on the market right now for pediatric patients are omalizumab, which is anti-IgE, mepolizumab, which is an anti-IL-5. It prevents IL-5 from binding to its receptor. Benralizumab, another anti-IL-5 drug. Mepolizumab binds to IL-5. This binds to the receptor. And dupilumab, which is an anti-IL-4 receptor drug, so it blocks both IL-4 and IL-13 signaling. So the primary effect, and again, the take-home message on biologic therapy as of today, is that their primary effect is to decrease severe exacerbation. So the need for systemic corticosteroids, emergency room visits, or hospitalizations. And they all average about reducing severe exacerbations about 50 to 60%. So that's their primary activity. They'll have some improvement on reducing symptoms, but not so much day-to-day symptoms. So patients who don't have a lot of severe exacerbations are less likely to see improvement with this drug. As far as improving lung function, omalizumab probably has the least amount of effect on lung function. Mepo has some, and both benralizumab and dupilumab have actually been shown to have significant improvement on lung function. Who should get omalizumab? Again, patients who have allergic sensitization. You need to be sensitized to at least one allergen, have your IgE level within a certain range. You can't give enough anti-IgE if the IgE is too high. Requires injections every 2 to 4 weeks. There is an anaphylaxis warning on the box, but it's an incredibly rare occurrence. Mepolizumab, anti-IL-5, these are all subcutaneous injections, by the way. It's generally given every 4 weeks and is for patients it works best in patients who have high eosinophil count, greater than 150 microliters at screening or greater than 300 sometime in the past year. Every 4-week drug. There's a very small risk of anaphylaxis, and some patients have developed zoster after these injections. Benralizumab is the anti-IL-5 receptor drug. And this drug has the advantage of being given every 4 weeks for 3 injections and then only every 8 weeks, so less of a burden for the patients. There's no requirement for eosinophils for this drug, but patients who have higher eosinophil counts and exhaled nitric oxide have a better response. Dupilumab, the anti-IL-4, IL-13 drug, again is given sub-Q once a week, and then it's given every 2 weeks, so again, a little less patient, or a little more patient burden here. Again, this drug works better in patients who have higher eosinophil counts and higher exhaled nitric oxide counts, but there's no specific recommendation for that. This drug and the mepolizumab can now be given at home. They come in little self-contained injectors, so again, it results in a little less patient burden. All these drugs work. This is one study on omalizumab showing that there's a modest degree of improvement in daily symptoms, definitely a decrease in exacerbations, and the patients were also able to decrease the amount of other controller that they took. This is just this is a comparison of the decrease in exacerbation rate across a number of studies with omalizumab. And you can see, depending on how long the patients took the drug, what the patient cohort, the ages of these patients look like, there's a lot of variability, but it averages out probably about a 50% reduction in exacerbations. This is mepolizumab. This is from one of the original studies. Again, this is the number of exacerbations over time, and you can see about this 50% reduction with 2 different doses of mepolizumab. This is a study on dupilumab and showing again the decrease in exacerbations favoring dupilumab versus placebo. And what you can see here is that the higher the eosinophil count, the greater the effectiveness of the dupilumab in these patients. This is a 200 milligram dose. 300 milligram, there's really not a significant difference here. Dupilumab has the advantage that it also has a pretty striking effect on improving eczema in patients. So if you have an allergic patient with eczema as well as asthma, it can be a double benefit. And this is just the data showing the improvement in dupilumab, or the improvement in FEV1 over time with dupilumab versus placebo. So improves symptoms, improves exacerbations, and lung function. So we have all these drugs. I'm not talking about reslizumab. That's an IV drug and is not approved for pediatric patients. So what's the big problem with these drugs is they're very expensive. So they're about $36,000 to $38,000 a year compared to probably about $5,000 a year for high-dose inhaled corticosteroids and a long-acting beta agonist. Not many patients pay this out of pocket, but it's a very expensive drug. So what would you like or is there a way that you should decide who should get these drugs? And you'd like to know that a patient has an adequate response to them. That means that they should have at least 50% fewer exacerbations in the previous year and or that they should be able to decrease the amount of controller medications that they take. So this study was published about a year ago now, and I thought it was a pretty brilliant strategy to try to decide who should get an expensive drug, such as a biologic, and how do you know if they've improved. And the paradigm went something like this, that the patient was given a 30-day trial of maximal medical management while their adherence was monitored electronically. Those who had poor adherence and poor control really needed to work on their adherence and taking their medications. Those who had good adherence, greater than 70%, but still had poor control, those patients probably belonged on a trial of biologics. And those that had good control, good adherence, and their control improved, well, let's just keep up with that plan. So I think this is an excellent way to think about who should get a biologic and how should you monitor its effectiveness. Spend just the last couple of minutes talking a little bit about other forms of therapy. Many of these are directed at patients who do not have eosinophilic allergic inflammation. So what about macrolide antibiotics, which are sort of the darling of many chronic respiratory conditions? We know that they can be effective in a number of other chronic forms of airway disease, COPD. They certainly have anti-inflammatory effects on neutrophils, on macrophages, on the epithelium and lymphocytes. There's certainly have antibacterial activity, and there's some evidence they actually have some antiviral activities as well. And again, in the phenotype of the patient who has neutrophilic asthma, they might be of use. There's a recent study and a warning published that at least in adults, there may be some increased cardiovascular risk with using macrolide. There's still not a lot of pediatric data. This was a study published in the Lancet on adult asthmatics that had moderate to severe asthma and took azithromycin compared to placebo, and again showed that they had a significant decrease in the number of exacerbations over time. We need more data on using these drugs in pediatric patients. Other potential treatments, bronchial thermoplasty, in which a lobe or maybe two lobes of the lung are treated with microwave, doing a flexible bronchoscopy and 3 treatments to decrease the smooth muscle mass. Can work in some adults. It's a highly invasive procedure. For the past couple of years, there's been some talk about trying this in adolescents. That, to my knowledge, has still not gotten off the ground. The other drugs that show some promise are anti-prostaglandin D2 inhibitors and TSLP inhibitors. There's a monoclonal antibody that's been studied here. These drugs are in clinical trials. There's some probiotics that are being considered mostly as preventatives for asthma, as well as supplements to improve control. Antifungal agents have been effective if a patient has allergic bronchopulmonary aspergillosis, but if someone just has a severe mold allergy or mold exposure, they're not recommended. The ancient drug theophylline is a wonderful drug, has some inflammatory properties, probably improves steroid sensitivity in some patients, but is very difficult to use. Allergen immunotherapy. We said most of these patients are highly sensitized to allergens. Can they get immunotherapy? Well, allergen immunotherapy can work. The problem is if you have a patient who has poorly controlled or unstable asthma or low lung function, allergen immunotherapy is considered not safe. So the patient needs to have better controlled asthma before they can get allergen immunotherapy. So to summarize, the take-home messages here is is the patient you think has severe asthma, do they have asthma? And is it severe, or is it just therapy? Is it therapy resistant or just difficult to treat? If you address their comorbidities, would the asthma suddenly move out of the severe realm? So you need to identify and manage comorbidities in these patients. Look for the common ones: unrecognized allergy or allergen exposure. Is the patient obese, and can you address that? Do they have obstructive sleep apnea, reflux, or is it the dreaded vocal cord dysfunction syndrome? So all that leads to trying to do your best to assign a phenotype to this patient, understand what endotypes or probably pathways are just driving the severe airway inflammation, and then try to devise a treatment plan that will be as specific as possible, and never forget about adherence with any of these therapies. So I think I'll stop there, and if anybody has any questions, I will be happy to answer them.
All right, thank you very much, Carolyn. That was a really great talk. Yeah, so if anybody has any questions, please type them into the chat box to start with, and we'll kind of go down the list. Carolyn, maybe can you comment while we're waiting on what sort of resources does your clinic have, or what can our fellows be looking for in practice in terms of creating environmental changes? There are public health nurses, social workers. I'm not sure what sort of resources your clinic has to try and help some of those.
Sure. I'm not sure if you're, well, not entirely sure what you're referring to. I think but we do spend a lot of time on non-medical interventions, and we do have medically trained social workers in our pulmonary clinic, and we actually have medically trained social workers or some health educators even in our general pediatrics clinic that really do try to work on adherence and a lot of the social determinants of health. So making sure patients can get their medications, addressing housing concerns, environmental concerns. We do have some programs with Hamilton County here to address housing concerns, largely things with water damage, mold, pest infestations, to help get those identified and then addressed. So those are certainly areas that you can help with comorbidities that can drive severe asthma for these patients. So really shouldn't underestimate that. And again, I think that oftentimes patients who get labeled as severe asthma really have difficult to treat asthma because of those comorbidities, because of bad adherence, or because of environmental exposure. So I don't know if that answered your question or not, DB, but.
Yep, that was, yeah, exactly. That's exactly what I had in mind. We had some resources here, some overlapping, some difference. Interesting to hear that in general peds you have some resources as well. So
yeah, well, we're very fortunate here. We've had a long ongoing partnership with our general pediatric colleagues, and something called an Asthma Improvement Initiative that was very successful in doing that. A lot of shared care practices between the specialists and the generalists. So looks like maybe you have a couple questions.
yeah, it looks like a question came through the chat questioning about monitoring and weaning on omalizumab, and I suppose other biologics as well. It looks like she wasn't finding any literature regarding how to wean or how to monitor.
Yeah, the reason you really probably haven't found any literature is there really isn't any, and it's a problem, and I'm glad that question was asked. It's a problem with most of the biologics is it's very difficult to decide when to stop. Might not be nearly as hard to decide when to start, but can you wean somebody off of these medications? I think the answer is there's no good evidence that any of them are disease modifying. So in the long term, we wouldn't expect that, oh, after 2 years, 3 years, 4 years of therapy, you can get somebody off. Having said that, I think we've had some successes in taking patients off of biologics over time, and I think the one I've had the most experience with is omalizumab. And some of that in part might be that over time some of the allergen exposures that the patient has. Most of the kids who are on omalizumab are on because they have a high degree of inhalant allergic sensitization. And over time, they certainly may have changed their environment, have less exposure. They may have had just those allergies sort of burn out a little bit over time, and then you're able to actually wean them off or even stop the omalizumab. But I don't know that that's an inherent property of the biologic, and I think the same thing is true with the others as well. So it is a problem. There's not a good way except to do it empirically.
Great. Yeah, I think next question is on determining adherence. How do you track? You rely on the pharmacy.
Yeah, that's a great question as well, and the answer is we do a little bit of everything. So for pretty much most of our patients who have severe or difficult to treat asthma, we do indeed call the pharmacy. So that's imprecise, and patients do sometimes visit multiple pharmacies, but at least try to get a handle on their refill history. We do some degree of electronic monitoring. We do have an active group in our psychology and behavioral medicine group here who are very interested in adherence. In fact, if anybody's interested out there, we actually have a combined fellowship in medical adherence. Several of our pulmonary fellows have taken that actually, but we have a very active group that has studied a variety of electronic monitoring devices. I said those are becoming much more available. Smart inhalers are probably going to be on the market for many more medicines very soon. Some of that can be circumvented as well, but I do think it's vital, and I do think that most of the patients are not taking the medicine every day, and they're not taking the medicine as prescribed. That may be okay for many of our asthmatics, but it's often not okay for the patients who have the more difficult to treat or severe asthma. So you do have to really work on monitoring.
Great. Any other questions that are out there? Yeah. So it looks like one of our fellows, Eli Rhodes, is asking about preschool group, challenging to diagnose and define asthma. We have patients, though, it seems like have minimal baseline symptoms, but have severe admissions, even admissions to ICU. Do you have a threshold for ICS-LABA in the preschool age group and any insurance issues?
Yeah, it's another great question, and absolutely right that we all have a handful. Unfortunately, it's usually only a handful of those fairly young kids who are fine until boom, they're not fine and they're sick enough to be in the ICU. And I think that they have some very interesting, very frightening phenotype that I don't think is well understood and is a little bit hard to study. But we pretty much do the same thing with those kids, really try to identify, do they have early atopy, do they have a lot of eosinophils, and if we think that that's the phenotype that they have, we certainly will go ahead and put them on either high-dose steroids or an ICS-LABA. Again, very, very little data on using those drugs in young kids. I'm not sure. Well, I take that back. I have a BPDer who has sort of vicious airway reactivity and has had eosinophilia, who is 2 years old and is on an ICS-LABA combo. We have a couple of kids about age 3 that are on those drugs now, but again, they really do have to meet that criteria. Very, very severe, lots of ICU admissions. I don't think we've had insurance issues with denial because the kids are too young or are under the FDA approval ages. I just think we just don't have a lot of data about the proper dosing for those drugs, and I do think you have to monitor them for steroid toxicity if you're going to use them. We do tend to give those families EpiPens. So if the kid has a very profound, severe, rapid onset episode at home, teach the parents to use that, obviously, while they're seeking medical attention.
All right, and it looks like Liz put one more question there from one of the fellows. What's the protocol for obtaining pheno? They say in the hospital. I guess the question is, do you obtain this in every patient with severe asthma?
Yeah, we do obtain exhaled nitric oxide in all of our severe patients, severe asthma patients. We don't do a lot of it on the inpatient side, but certainly in the outpatient clinic. So the devices are really pretty available. The prices come down, and it shouldn't be a problem to get exhaled nitric oxide. The problem is on age. You know, there are some 4- and 5-year-olds that can do it. There are some 16-year-olds that can't do it. So we usually will try, certainly if somebody's 5 or if they can do a spirometry, but that's not a guarantee either. But we'll try on all the patients to get an exhaled nitric oxide.
Okay. And then I guess a tangential question, he says, in patients with severe asthma and high IgE, do these patients also have high eosinophil counts in their BAL? Do those strictly correlate, you know?
Yeah, that's a great question. I think, you know, certainly some patients have both a high IgE and high eosinophils. As far as do they have it in their BAL fluid, not always. Again, I think over time that peripheral blood eosinophil count has really been found to be pretty useful, and in some studies probably more useful than eosinophils in the BAL. And the thought is that a lot of the airway eosinophils are in the submucosa. They're not coming out into the BAL fluid. So that even if you don't have it on a bronch, doesn't mean that there's not a lot of airway eosinophils. But for some reason, the circulating eos really are a pretty good biomarker. So we'll often go with that. The trick is you just can't have the patient on systemic steroids, you know, anytime in the previous couple of weeks. They'll just really blow away eosinophils. I know a lot of our residents are always trying to get CBCs in the patient who's in the hospital who's had a couple of doses of steroids, and it's pretty useless, so just can't do that.
All right. Well, great. Thanks. I guess we have, if anybody else has any questions, please type them in. The SurveyMonkey link is up there in the chat. For everyone, please go fill out the feedback for this webinar. Again, our next talk will be Wednesday, same time at 4 o'clock Eastern. And that would be Chris Orman talking about congenital abnormalities of the lower airways and lungs.
He gives a great talk, by the way. Y'all ought to listen to it. It's a fabulous talk.
Definitely. All right. Well, thank you very much, Carolyn. It was a really great talk.
My pleasure. Good luck to everybody.
And thanks for everybody for logging on. It was a really great turnout. Thanks for sticking through to the end.
Okay. Bye-bye.
All right. Bye.